हेमंत भाई, हे रमेश कुमार वगैरे कोणी जॉईन करणार आहे का?
Good evening, everyone. On behalf of Maharashtra Academy of Pediatrics, I welcome all the respected dignitaries, seniors, colleagues, and our live YouTube attendees to yet another interactive academic session on pediatric tuberculosis. Before we start, I request everyone to please keep their mic on mute, and if any queries, then can put them in the chat box. It will be attended at the end of the session. Friends, children are the world of tomorrow, and we are failing on so many fronts: health, poverty, climate. Tuberculosis remains the Cinderella of infectious diseases, heavily impacted by the absence of collective commitment to save young lives. Not many people realize that a rise in the number of children with tuberculosis in a city or country means ongoing and high transmission as children are infected by the adults around them. We cannot continue to stand on the sideline while children and adolescents fall ill and die, especially when we know how to prevent and treat them. So today, MahaAPI has arranged an exclusive academic session, Champions for Children and Pediatric TB by 2025. Now for the opening remark, I would like to invite our MahaAPI President, Dr. Hemant Gangulia, sir. Welcome, sir.
Thank you, Dr. Neha. Namaste, our chief guest, Dr. Jayant Upadhyay, sir, Vice President, West Zone, CIP 2021, as well as Dr. Bela Verma, Madam, from JJ Hospital, as well as our esteemed faculty, Dr. Ramji, sir, Dr. Satish, Dr. Shushant Manessa, as well as Dr. Mayur, who is a coordinator from Sati, all the attendees of this meeting, as well as all the attendees. I remember when we just attended a program which was held on 30th of December at Pune, when Sati invited to just invited for that program. The program was so much, the program was CAP TB. It was so informative, and I felt, frankly, I was missing something. I didn't know many things of that. And that time I realized across the Maharashtra state, whether all general pediatricians are aware of this. Though there are algorithms, though NTP program, National TB Elimination program, was launched in 2020, and I remember distinctly the third program of NTP was done at Alibag when we were the host as IIP Raigad. And after that, because of all Corona pandemic, it went back. So that time I realized, let us sensitize the basic things. What are we missing pediatric TB as a general pediatrician practicing at periphery? And I thought, I felt that day that there's some still communication gap between the government setup, private setup. Is our private pediatrician should treat or not to treat resistance problem? So many questions, queries were raised on that program. And so I thought, okay, let us sensitize everybody. Let us hear from all the experts what is the problems and how we can go for this elimination of TB from our country. So with that note, I welcome everybody, and let us have a good academic knowledge regarding this pediatric tuberculosis. Thank you very much.
Thank you, Gangulia, sir. Today, we are glad to have with us Dr. Bela Verma ma'am and Dr. Jayant Upadhyay sir as chief guest. Dr. Bela Verma ma'am is professor and head of pediatric department at Grant Government Medical College and Sir JJ Hospital, Mumbai. She was past president of IIP Mumbai in 2018-19. She was member of Maharashtra Task Force of Pediatric COVID Management 2021-22. At present, she is EB member of Central IIP 2022. Welcome, ma'am. Kindly unmute and give your blessings.
Yeah, good evening, everyone. Respected dignitaries on the desktop, and all my dear colleagues. We all know, and already it has been said by Neha very nicely, that we have been struggling not only on a national level, but also on a global level to control and eradicate TB for the last almost 25-30 years. And now with the increasing prevalence of drug-resistant TB, the fight has only got more tougher. And every year, the changing guidelines mandate that each treating pediatrician as well as a physician should be educated regarding the early diagnosis and appropriate management, as we all know. And the important thing is that the high prevalence of pediatric TB is actually a reflection of the ongoing adult tuberculosis, which Neha has rightly said. So unless each adult treating physician is also trained to know how to do a proper and complete management of tuberculosis, managing pediatric tuberculosis is going to become very difficult. And therefore, we have to do contact tracing and see that everyone who is a potential case of TB is also treated. Basically, we in the cities often get the updates, but it is now whatever Sathi is doing, and at a national level, the NTP program is there. We have to reach out to each pediatrician in the country so that they are educated and they do the proper diagnosis and appropriate management also of the tuberculosis in children. And I'm proud to say, Shushant is also here, that JJ has become a center of excellence for tuberculosis referrals, admissions, and management. So we all 3 units are we get patients from all over Maharashtra as also from out of Maharashtra sometimes for the management of difficult cases of tuberculosis and MDR tuberculosis. And therefore, all the best to this program. And I thank the Maharashtra IP for inviting me to be part of the session today. Thank you.
Thank you, ma'am, for such precious words. We also have with us Dr. Jayant Upadhyay, sir. He is consulting pediatrician at Nagpur. He was Vice President, Central IIP West Zone 2021. He was the EV member of Central IIP for 3 years. Sir was National Coordinator, Convener, and faculty for several Central IIP workshop modules. He was Chief Organizing Secretary of Pedicon 2018 Nagpur. He was Conference Chairman, West Zone Pedicon and Maha Pedicon at Alibag, and Chief Organizing Chairman of West Zone NNF and Maha Neocon at Nagpur in November and October 2021. Welcome, sir. Kindly unmute, sir.
Good evening. Thank you, Dr. Neha, for such a nice introduction. Respected Dr. Ramesh Kumar, Dr. Upendra Kinjodekar, Dr. Piyush Gupta, Vinit Saxena, Samir Dalwai, Purna Kurkure, and all the office bearer and executive board member of CIP. Some are present there, some in their absentia. Respected Dr. Hemant Gangulia, the respected president of Maharashtra IP, Dr. Vinayak Patil, Vice President, Amol Pawar, Secretary, Dr. Mohan Warke, Dr. Jay Bhandarkar, and so many names to take, all the respected EBs and OBs of MahaAP. Dr. Bela Verma, Dr. Narendra Naniwadekar, Dr. Pramod Kulkarni, Dr. Sanjay Deshmukh, and Dr. Ramakant Patil, all respected executive board member of Central IIP from Maharashtra. All the respected personalities on the virtual diet and those who are connected on live YouTube link. First of all, I welcome you all as the chief guest of today's function. I'm very grateful to the MahaIP 2022 for inviting me as the chief guest of this function. As already been highlighted by Dr. Neha, Dr. Hemant Bhai, and Dr. Bela Madam, today's program is Champions for Children in Pediatric TB by 2025. Today's guest faculties will be Dr. Shushant Manessa, Dr. Satish Kumar, and Dr. Ramji Adkikar. Coordinator for in Maharashtra, Dr. Mayur Munne. There are few points which are very important why we are aiming and we are targeting. MahaIP is giving so much importance to NTEP program, already been highlighted by Hemant Bhai. There was a shift from National Tuberculosis Control Program to NTEP 2 years back. There was a big push by our Honorable Prime Minister, Dr. Narendra Modi ji, for that. And now we are going ahead with not controlling the TB, but eliminating the TB. As Neha has already said, children are sufferer because of tuberculosis in adult, and the form they take, like miliary tuberculosis, disseminated tuberculosis, tubercular meningitis, and so on and so forth, is really the mortality and morbidity is added because of this complication, rarely seen with adult patient. Now there is, hello, Deepak, Dr. Deepak, please mute. There is a lot of support from central and state government in giving a push to start with this national tuberculosis elimination program. This is being implemented at state as well as central level. A lot of reorganization has gone into it. Training programs, supply of the equipments, supply of pharmacological agents in diagnosis, in treatment. Now the level, the ante has been up by state and central government. There are so many difficulties and dilemmas in diagnosis and treatment of tuberculosis. CBNAT machines have been provided, free drugs are being provided. Now the aim basically is at microbiological diagnosis rather than clinical diagnosis, although we have to go ahead with clinical diagnosis in many instances. Not only the microbiological diagnosis gives you the confirmation, but it also gives you idea about the resistant type of tuberculosis, drug resistance tuberculosis, what type of resistance it is, and what is the pattern, what needs to be done. The guidelines are provided in NTEP module of IAP. So this is a sensitization sort of program, and I must congratulate Dr. Hemant Bhai, Dr. Amol Pawar, and entire Maharashtra IAP, EB and OB to kickstart this program right in the month of January, and a more impetus will be there on implementation and training of pediatrician at grassroots level. That is what is being required, not only in the cities, but at a very small village level also, the things will start moving. So I wish all the best to all the stakeholders, and especially to Maha IAP and Central IAP. Thank you. Thanks very much.
Thank you, Upadhyay sir, for your valuable words. For today's CME, we have with us three eminent guest speakers who will be delivering their talk on three different topics. First, I would like to welcome Dr. Shushant Manessa. He is Associate Professor in Pediatrics, Grand Government Medical College, Mumbai. He is working as an expert in Child and Adolescent Tuberculosis Working Group WHO. He is also in charge of the State Pediatric Center of Excellence for TB and Pediatric Asthma Division. He will be speaking on basic of pediatric tuberculosis. Sir, kindly unmute.
Yes. Good evening, everybody. Yeah. So should I start? Yeah.
Yes, sir.
Let me share my screen. Yeah. I hope it is visible now.
Yes, sir.
Yes, sir.
So good evening, everybody. At the outset, I would thank the office bearers of Maharashtra IAP for having this session and inviting me to share my views and experiences on pediatric tuberculosis. As everybody has rightly said, today time has come that not only people working in the cities or people working in corporate hospitals or medical colleges should know about tuberculosis, but each and every pediatrician who is even working at the grassroots level should know at least the basics of how to diagnose and how to treat the basic tuberculosis, at least the drug sensitive one. So whatever I'm going to speak today is from the NTP module. These are not my opinions, these are not my views, these are all standard guidelines which are put forward by WHO and incorporated by our National Tuberculosis Program in conjunction with the Indian Academy of Pediatrics. So everybody has spoken that childhood TB is increasing. It is a reflection of the adult TB. because adult TB has increased, we are seeing more and more cases in children. All this is known. They are having so much of burden in children. What I want all of us to focus is on this aspect, that is the detection gap of TB. Now, this has been proved well beyond doubt. This was a literature which was published in the late 2019, in somewhere around December or November 2019, that the detection gap for children with tuberculosis in the age group of 5 to 15 years is about 56 to 60%. And this increases to more than 70% in children more than 5 years. What do we mean by this? By this, we mean that around 70% of pediatric TB children less than 5 years of age, we are actually missing. Now, the reasons for missing these children could be many. Either the parents or the children are not coming to our clinics with their symptoms. Second, they are coming, but we are not able to pick up the signs and symptoms. If we pick up the signs and symptoms, we don't have the diagnostic facilities, or basically we don't have the knowledge about what diagnosis is available, and so on and so forth. So that is why this sensitization is arranged today, so that we are all, experts, we can say, or the core members, where if we get sensitized today, we are going to take this NTP program forward in the smallest of the districts and the towns of Maharashtra. So as far as symptom characterization is concerned, when do we say or when do we suspect any of our patient is having tuberculosis? So there are three basic symptoms which all of us know. First is a persistent and unexplained fever. Now, each one of the words is important. Persistent means the fever has to be there almost on a daily basis. It has to have a minimum temperature of at least 100 degrees Fahrenheit or 38 degrees centigrade, and it should be running for a minimum period of about 2 weeks. An objective recording of the fever, if possible by the parents, is always welcome. Second is a persistent cough, which is lasting for more than 2 weeks. Again, the cough has to be persistent. Now, here comes the importance of history. Suppose if a parent is telling the child had cough for around 10 to 15 days last month, then the child was absolutely asymptomatic, and again the child is having cough, this becomes a recurrent kind of a cough. So the duties of recurrent cough are different. So when we are talking about a tuberculous cough, it is a persistent cough. Either it is remaining same without improving, or it is worsening over a period of 2 weeks or more. And the third criteria is a history of weight loss or failure to thrive or no weight gain. So if we have previous records of the child, that is the past 2 to 3 months records, if there is a definite documented record of more than 5% weight loss in the past 3 months, or there is a failure to gain weight. Now, when we take this history or when we do this objective measurement of weight, we have to confirm that the child is not fitting into malnutrition, the diet of the child is okay. In spite of all these things, the child is not putting up weight or not gaining weight, then we suspect that this could be one of the symptoms which is suggestive of tuberculosis. Now, these three symptoms, that is fever, weight loss, and with or without cough, are common for any type of tuberculosis, whether we are talking about pulmonary TB or we are talking about extrapulmonary tuberculosis. In addition to that, when do we suspect extrapulmonary TB is any suspicious swellings if arise into the body, most commonly cervical lymph nodes, sometimes axillary or inguinal lymph nodes, any chronic low back pain, especially pot spine comes with a chronic low back pain, any meningitis of insidious onset. Basically, what we want to sensitize here is any patient coming with a chronic symptom of more than 2 weeks, with or without a history of tuberculosis, in today's age, we must keep TB as one of the differentials. It may not be always there, but you have to keep as one of the differentials. So the next step is, if we have such a symptom characterization, what is the significance of exposure, or how do we ask the history of exposure? So we all know if there is an index case of pulmonary tuberculosis in a family. Now, by pulmonary tuberculosis, we mean either it could be a parenchymal lung disease or it could be an airway involvement. So any type of pulmonary TB index case in the family, he is a potential spreader to the other close household contacts. If we have such a history, all the household contacts, irrespective of the age, whether it is a pediatric or whether it is an adult, have to undergo screening. It is a symptom-based screening. And if symptoms are suggestive, we go ahead with certain kind of investigations. Now, there is one more point to this. Now, if a child comes to us with a history of symptoms suggestive of tuberculosis, then even if there is a history that in a household, the index cases of an extrapulmonary TB, for example, an abdominal TB or maybe a TB lymph node, still this is significant, because we never know, in an adult with an extrapulmonary TB, there can be a hidden pulmonary focus. And we have to ask the history for the past 2 years, because 2 years is generally considered as a natural course during which tuberculosis of various organs may come up with. Like for example, a pleural effusion may come up somewhere around 6 months to 8 months. Pulmonary TB may manifest 6 months to 9 months after a first exposure. As opposed to that, a spine TB or osteoarticular TB may take sometimes 1 year, 12 months, or 15 months to manifest once the exposure is done. So history of exposure is very important. And believe me, when we are asking the history of exposure, not only history of contact with an infectious TB case in the household, but any close contact. What happens, or what commonly we ask is, घर में किसी को TB है क्या? And most of the times the answer is no. Either actually there is no patient in the household, or even if the patient is there, there is a certain kind of still stigma associated with TB and the patients don't come out with a history. But then if somebody is an open case in the neighborhood of the child, or suppose a relative, distant relative who keeps on coming to the home of the child, even this history is important. And therefore we should not limit our history of exposure to just asking whether there is a history of exposure within the household. Any close contact is important. So when we have a patient with TB suspect, when do we call a patient who is a TB suspect? Now, first and foremost, what we must learn here is the terminology suspect is no longer used. Now, the terminology is changed to a presumptive case of TB. So any child who is coming with these 3 cardinal features, which we just learned, is considered to be a presumptive case of tuberculosis, which means there is a possibility that this child is suffering from tuberculosis. Once we have this presumptive case, which is fitting into the definition of a presumptive TB, then how do we proceed with the further investigations of this child? So what are the challenges? So we have a case who is fitting clinically into a diagnosis of TB, a presumptive TB. We know that these clinical features are not specific, though they are highly sensitive, but they are not specific. There are so many other conditions which can come with similar features, fever more than 2 weeks, or maybe weight loss, something like that. Again, even if we think of tuberculosis and getting a microbiological investigation done, getting a sample from a child is difficult. A child who is 5 to 6 years and above, we can train the child to give an expectorated sputum. Less than that, we have to rely upon methods like a nasopharyngeal aspirate or a gastric aspirate in this child. Again, it becomes an invasive procedure. Even if we do the procedure correctly, we get the sample properly, we know that childhood TB is a possible axillary disease. Because it is possible axillary, most of the times the smear comes negative. Yes, initially we didn't have any specific point of care diagnostic test. In today's age, we have a biggest test, which is Gene Expert, or we call it as CBNAT, that is cartridge-based nucleic acid amplification test. So this is a highly sensitive test as compared to a smear. But again, it depends upon what sample we are taking. And most importantly, this we are talking about pulmonary TB. When we come across samples like a lymph node sample or an extrapulmonary TB like an abdominal TB, in a case of lymph node, if we happen to do an FNAC, most of the time the Gene Expert reports comes negative. We have to again go ahead and do a biopsy or something like that. In case of abdominal TB, sometimes the lymph nodes are in such a difficult location, we are not able to get the lymph node sample. There again, we have to rely more upon our clinical acumen or clinical diagnosis, and therefore our clinical diagnosis has to be robust. But in addition to that, we also have to make attempts to get a microbiological diagnosis. So once we have a patient, so this top box is going to keep on repeating in our presentations. So once we have a patient who is having symptom complex suggestive of TB, the first and the initial screening test is always an chest X-ray. Now today we'll be talking primarily about pulmonary tuberculosis. Extrapulmonary, because we have limited time, we are not going to deal with extrapulmonary, but definitely any questions are there, I request you to put it in the chat box. We will answer it at the end of the session. So X-ray is a very important diagnostic tool, and therefore each and every one of us, even the basic pediatrician, must be well versed how to read an X-ray chest. This is because, as we just said, that many of the times, because of the possible axillary nature, the microbiological test comes negative. Sometimes we are not able to get adequate sample, and then we have to rely upon our clinical diagnosis. What do you mean by clinical diagnosis? The symptom complex and the X-ray chest. And therefore, reading of X-ray chest is a skill which each and every one of us should develop. Because if we don't read the X-ray properly, we may either tend to underdiagnose TB, or we can also overdiagnose TB. We also see certain cases where actually the child is not having tuberculosis, but the child is put on treatment for tuberculosis. So when we talk about X-ray as the initial screening test, there are certain characteristic features on the X-ray which are highly suggestive of TB. So which are these highly suggestive features? There are 3 basic features. One, when we have any sort of lymphadenopathy on the X-ray, which is the first X-ray, either a paratracheal lymph nodes or subcarinal lymph nodes or hilar lymph nodes. Second, if we have a miliary pattern, which we can see in the middle X-ray. And third, when we have a fibrocavitary disease. When any one of these patterns is present in a symptom background suggestive of TB, it is highly suggestive of tuberculosis. We must also be aware of certain confounders. Sometimes we may have certain summation shadows which come up, certain overlying structures, if the the hair coming into the X-ray film, thymus obscuring, or thymus causing a false impression of lymph nodes. So all these are important artifacts, or I can say, or confounders I can say, and therefore, as we said, reading of X-ray chest is very important. So once we have an X-ray chest which is there, do we have a confirmed diagnosis? No. So yes, we have a symptom complex suggestive of TB. We have an X-ray there where it is showing a left paratracheal lymph node. But in today's age, just by having symptoms and an X-ray suggestive of TB, the diagnosis is neither confirmed nor complete. Now, what do you mean by these two terminologies? Is a confirmed diagnosis is where when we are able to diagnose Mycobacterium tuberculosis either on a smear or on a CB-NAT, that is our gene expert. And the diagnosis becomes complete when we know the resistance pattern of this organism, at least to rifampicin. That is what our gene expert tells us, whether MTB is detected or not detected, and whether it is resistant to rifampicin or not resistant to rifampicin. So this becomes a complete diagnosis as far as diagnosing any patient of pulmonary tuberculosis is concerned. Now, why this is done is because now the goalposts have changed. Initially, it was only about MTB detection. Now it is, in addition to MTB detection, we have to detect rifampicin resistance. This is done because we are having increasing number of cases of drug-resistant tuberculosis, not only in adults, but also in pediatrics. And this is not the scenario just in Mumbai where we practice, but it is the scenario all over the country in each and every state. The thing is that we are just missing this diagnosis. And the diagnosis has been made much more easier and faster because of the rapid molecular tests which are available to us. That is your gene expert. Then we have our LPAs, that is line probe assay, which not only help us to pick up the diagnosis of MTB early as compared to our smear and traditional cultures, but they also give us upfront resistance to not only rifampicin, but also the other second line drugs. So what has been a strategic shift in the diagnosis? So first and foremost, as we said, we have rapid molecular tests which are approved not only by WHO, but also incorporated in our National Tuberculosis Program of India. They are faster than the conventional methods and they give a more confirmed diagnosis. The second concept which we all must know here is today is the age of UDST, or what we say as universal drug sensitivity testing. Now, what do we mean by universal is, universal does not mean testing of resistance to all the drugs, but universal means testing all the patients for drug sensitivity. And what drug we test for sensitivity? We test only one drug first, which is rifampicin. So that is what our gene expert does. It gives the diagnosis of MTB detected and it gives the resistance pattern to rifampicin. Now, this concept of universal DST was followed till 2019-20. Now, there is one more addition to the concept of universal DST, which is if we get a gene expert report of MTB detected and rifampicin resistance detected. So if we have a MDR TB and if we have facilities, we have to run the resistance for at least fluoroquinolones because we are getting more and more cases of pre-XDR TB. So the universal DST concept refers to testing all the patients, that is a specimen retrieved from all the presumptive cases of TB for testing of rifampicin. Now, why only rifampicin was chosen? The reason for this is that is the most common resistance to TB which we see in the community. Rifampicin is the single most drug to which resistance has been seen in majority of the cases, whether it is MDR or pre-XDR or XDR. The resistance to rifampicin is very easy to pick up by our molecular test. There is only one gene, that is the RPO beta gene, which gives rise to around 92 to 94% of rifampicin resistance in the community. Okay. Like, for example, fluoroquinolones have multiple genes which can be mutated and resistance can be there at multiple levels. It is difficult to pick up by test. And because of this, if we don't pick up rifampicin resistant, we can inadvertently keep on treating patients with treatment for drug sensitive TB when actually it is a drug resistant TB. And this is going to complicate the situation much more. The patient is not going to respond. We will lose the patient. But in addition to that, the patient is going to infect the close contacts around him with a drug resistant strain. So as we know, we have to do a microbiological diagnosis, but there are certain hurdles. We have seen that the children are not able to get out sputum. It is a possibacillary disease and the traditional cultures take a long time to grow. But whenever there are hurdles, there are always solutions which are available. So we know that if the children are not able to expectorate, we are supposed to take a gastric aspirate or an induced sputum. Now this has been tried and tested that gastric aspirate is also a very good sample if it is collected properly and the sensitivity of CB that is good. WHO in 2021 has also approved nasopharyngeal aspirates and stool as one of the specimens for gene expert, which will be coming shortly in our guidelines. The most important thing is how do we collect specimens? The Central TB Division has formed beautiful videos on how to actually collect a gastric aspirate, how to do an induced sputum, how to give a Mantoux test. I'm sure they are there on the Central TB Division site. My Sathi colleagues will definitely share the links of those videos with all of us after this session is over. Whenever we're talking about possibacillary, now we have molecular tests, so it has increased sensitivity, and cultures, all the traditional solid cultures which were used are now replaced by liquid cultures. So all cultures, what we do now are liquid cultures because they are faster. Solid cultures used to take 8 to 12 weeks to give a final report. In liquid cultures, we can get a positive result as early as 2 to 3 weeks if the bacterial load is high, and they give a confirmed report at around 6 weeks. So again, these methods are faster. So this is what a gene expert machine looks like. So when we have an induced sputum or a gastric aspirate and we send it for gene expert. So basically there are two types of machines which are in use now in India. We have a gene expert or a CBNAT machine, and second, on the right side, what we are seeing is a TrueNAT machine. Now, what is basically a difference between two? These are both similar technologies. Both work on the basic principle of PCR to detect to amplify the bacterial DNA which is present, and it gives a positive result. Both of them will give us information whether MTB is detected or whether it is resistant to rifampicin or not. Then what is the difference? The difference is TrueNAT machine is a semi-quantitative machine. That means it is not fully automated. Some of the steps, that is DNA deannulation, DNA ligation, needs to be done separately, and then the sample goes into the machine and the machine gives the result. As compared to that, a CBNAT machine is a fully automated machine. Once you put the sample into the machine, all processes are carried out inside the machine and you get a final result. Now, you will say then why these two types of machines are used. These two types of machines are used because the TrueNAT machine is an Indian origin machine, which is developed by an Indian company, which is MolBio, which is located in Goa, and it is a much cheaper technology. It does not require a level 3, level 4 biosafety lab to run the machine. It is a small handheld machine which can be used even at the primary health center levels. And in many of the states, these machines have been put at the PSC level or the sub-center level by the government of India or the NTP program, so that more and more people get access to molecular tests. So whatever machine or whatever test is available with us, whether it is CBNAT or whether it is TrueNAT, we are supposed to use. The message is we are supposed to use this test, and the sensitivity of both the machines is same. So it is not like that CBNAT is more sensitive, TrueNAT is less sensitive, sensitivity is almost the same. So once we have a symptom complex suggestive of TB, once we have an X-ray suggestive of TB, we do a NAT and NAT comes positive, this becomes a confirmed case of tuberculosis, and then we label the patient as having a drug-sensitive tuberculosis if rifampicin resistance is not detected. When we have a pulmonary TB, we label it as a pulmonary TB. What we must understand, two things here is, the center star which is put here is notification is a must. It is a punishable offense now if we don't report any case of TB which we are diagnosing or treating. In addition to that, all children who are diagnosed with TB have to undergo HIV testing. It is a parallel program which runs the HIV program and the TB program. So culture I have just talked about. All are liquid cultures, which is known as our MGIT, that is microbacterial growth indicator tube. The advantage being it has a short turnaround time and we get the results earlier. So once we know all these things, that is, we know what is the symptom complex, we know that we have to do an X-ray chest, and we know that there is something known as gene expert, which we have to do. How does it all add up? That's where it gets us to the diagnostic algorithm of pulmonary TB. So here we need to have a few minutes of attention. So the first box again says, if we have a child who is fitting into the symptom complex of TB, the first test which we are doing is an X-ray chest. Now, if the X-ray chest is highly suggestive of tuberculosis, the three things: lymph node in the chest, that is paratracheal, hilar, or whatever lymph nodes, miliary or fibrocavitary pattern. So if the X-ray chest is highly suggestive of TB, we take a expectorated sputum or gastric aspirate or whatever sample for NAT, that is our gene expert. If NAT is positive, it becomes a microbiologically confirmed case of TB. If rifampicin resistance is detected, we treat as resistant TB. If resistance is not detected, we treat it as a drug-sensitive TB with first-line drugs. Now, if the NAT is negative, yes, it may happen. As we all know, the sensitivity of gene expert with in best of the hands and in best of machines is around 65 to 66%. So it is not 100% sensitive. 40% samples would still be negative. Then what do we do? So here is a case where we have a symptom complex suggestive of TB. The X-ray is highly suggestive of TB. Here, it is always prudent to repeat a CB NAT and get a better quality specimen. Maybe the initial specimen was not properly collected. Another option is we go to the periphery, check for the peripheral lymph nodes. Even in the case of pulmonary TB, if we get a very prominent cervical lymph node, we can sample that cervical lymph node and send. Maybe we can get CB NAT positive in that. So even if on second attempt, the NAT comes positive, again, it becomes a microbiologically confirmed TB case and we treat the case. If on second attempt, still the NAT comes negative. Now, here is a case where there was a very strong suspicion of TB clinically. The X-ray was highly suggestive of TB. We have made all the possible attempts to get a microbiological diagnosis. We have done expectorated sputum twice. Maybe we have done a cervical lymph node biopsy. After doing everything, the NAT is still coming negative. We don't have any other diagnosis but TB in mind. Here is a patient where we label it as a clinically diagnosed tuberculosis and treat the patient clinically with first-line drugs. Mind you, colleagues, seniors, ladies and gentlemen, clinical diagnosis of TB is allowed, but not at the first attempt. We cannot just start anti-tuberculous therapy to a patient who is having fever for 1 month and month 2 is positive. No, we have to make all the possible attempts to get a microbiological diagnosis. And if we don't get, there is a strong suspicion of TB, we are justified in treating the TB clinically. The second scenario would be the X-ray chest is not highly suggestive of TB. There are just non-specific infiltrates or just consolidation on the X-ray which is seen. In this case, we give a course of appropriate antibiotics to this patient for a period of 7 to 10 days. Now, here we must learn the antibiotic which needs to be used is either plain amoxicillin or at the most amoxicillin clavulanic acid. Please, we are not supposed to use linezolid. We are not supposed to use quinolones because these are very high-end antibiotics. And second, these are reserved drugs for treatment of MDR tuberculosis. So after a course of appropriate antibiotics for 7 to 10 days, if there are persistent shadows on the X-rays, then we again follow the algorithm. That is, we send a sputum for NAT and then we follow the algorithm. The third possibility is the patient is having symptoms suggestive of TB, but the X-ray chest is normal. Here, probably we are dealing with a case of EPTB, that is extrapulmonary TB. Now, this is a case which needs detailed investigations. We do not know TB can be sitting anywhere into the body, into the abdomen, into the kidney, anywhere. So this patient needs expert care, expert investigations, and we may consider referral of such patients to higher center. So once we have a presumed case of TB, the first investigation, what we do a CB NAT. So this I will tell you how the program is actually designed and how NTP proceeds with the sample. So once we have a NAT, if MTB is not detected or MTB is not detected, it becomes a clinical diagnosed case of TB. If there are no risk factors for suspecting drug-resistant TB, we start with first-line drugs, that is drugs for treatment for drug-sensitive TB. Now, if MTB is detected, but rifampicin resistance is not detected, that means again it is a drug-sensitive TB, we start treatment for drug-sensitive TB. The second possibility is rifampicin resistance is detected. Now, once the resistance is detected, as we just learned a few minutes back, as per the concept of universal DST, we have to know resistance pattern to fluoroquinolones also. So there are two types of LPAs, or what we say, line probe assays, the first line and second line. The first line LPA is a molecular test which will pick up resistance to isoniazid and rifampicin. The second line LPA would pick up resistance to our fluoroquinolones and our injectable drugs, that is amikacin, kanamycin, capreomycin. What we must understand here, if we are dealing with a pulmonary TB patient and if the smear is positive, we can do LPA on the positive smear, which is known as a direct LPA. And therefore, within 48 to 72 hours, we get the complete resistance pattern of the patient. However, being in pediatrics, most of the time the smear is not positive, it is negative. Only the gene expert is positive. Then what do we do? Then we have to wait till the culture comes positive. And once the culture is positive, on that culture isolate, the first line and second line LPA is done and we get the resistance pattern, whether it is H resistance or whether it is fluoroquinolone resistance and so forth, so far and so forth. If we are dealing with an extrapulmonary sample, for example, a lymph node TB, once the gene expert is positive, it is rifampicin detected, it directly goes for culture. Once the culture comes, again, a LPA is run, because for extrapulmonary TB, we don't prepare a smear. Now, if a patient who is started on treatment with drug-sensitive TB does not respond in a period of 4 weeks, mind you, the period is 4 weeks or 1 month, we have to start re-investigating for non-response. Possibly we are dealing with a drug-resistant TB child, and we have to send appropriate samples again for repeat NAT. If at that time rifampicin resistance is not detected, they run a first-line LPA. Maybe we are dealing with a case of isoniazid monoresistant TB. It looks complex, but once we start following it, it is not complex. One point I need to highlight here is all these tests are available absolutely free of cost under the NTEP, not only in government sector or not only in municipal sector, but also to all the private pediatricians. We just have to have the will. Our STO sir is also there. There are so many NGOs with which the program has partnered. You have to just get in contact with the district tuberculosis officer in your area, and he will mobilize everything for you. You can treat the patient in your own clinic. You need not send the patient even to a public hospital or a government hospital. How do we treat our patients? So it is simple. What are the new things which has come up in treatment? There has been an addition of ethambutol in the continuation phase. So we give, initially there was only HR in the continuation phase. Now why this has been done is, we are in India, we are seeing around 15 to 18% cases with isoniazid monoresistance. And therefore, if we give only 2 drugs in the continuation phase, that is H and R, and if it is a case of isoniazid monoresistance, practically we are having only 1 drug which is left in the continuation phase. This is the reason why ethambutol has been added in the continuation phase. If the patient is not responding at the end of 4 weeks or 1 month, there is no business that we extend the therapy for 1 more month or 2 more months. All this has to be given up. We start investigating the child for drug-resistant TB. Now we are giving daily therapy since 2015-16 to all the patients. Category 2, which was the initial category which included streptomycin, if the patient was not responding or failure patient, has been removed since December 2018. It is my earnest request to all of us, please, we should not use this category. Even in 2021, sometimes in our center of excellence, we get references where the patient has been started on streptomycin. Although streptomycin is not available through the program, the patient is prescribed streptomycin from a nearby chemist and the patient is put on that drug. So please, we are not supposed to use that. We have definite guidelines which are put forward. So the therapy is same for all the patients of drug sensitive TB. So basically, under the program, we have only 2 categories of therapy now, one for drug sensitive TB and one for drug resistant TB. When we're talking about drug sensitive TB, whether it is a newly diagnosed case, whether it is a recurrent case, whether it is a defaulter, that is treatment after lock to follow-up or a treatment failure, everybody gets same therapy, 2 months of HRZD plus 4 months of HRE. If we are dealing with a case of CNS TB or a spine TB, maybe we can increase the continuation phase to 10 months to complete the 12 months or 1 year of therapy. That is the only difference. The doses have gone up. Rifampicin is given in the dose of 15 mg per kg, isoniazid 10, pyrazinamide 35, ethambutol is given by 20. What I want to stress here is the fixed drug combinations which are available through the NTEP are a very good formulation which we can give to our patients. The biggest advantage is the patient does not have to take multiple tablets, and therefore forgetting of certain tablet is not a possibility. They are combination tablets. They are dispersible tablets, so our child can take it easily. Once we put it in water, they are dissolved. The combination is very rational. Only the ethambutol tablet is available separately. HRZ tablets are available in the combination. And most importantly, these drugs are of a very high quality. It is of the notion sometimes that the medicines available through government may not be of good quality, but I must tell you that these are very high quality drugs. They are supplied by McLeod's Pharma to the government of India, and all of our patients are treated with these drugs and they respond very well. The weight bands are given. We are supposed to treat according to the weight bands. So when we have a child who is not responding to our treatment, what do we do? First and foremost, we should actually see whether this is actually a non-response. What happens sometimes is, I just got a call 2 days back that a patient was started on treatment for drug sensitive TB, pulmonary TB. At the end of 2 weeks, the child is still having 2 fever spikes in a day. So we must know what is normal and what is not normal. Fever may take sometimes as long as 3 to 4 weeks to resolve. Cough may not go off completely for about 6 weeks or 8 weeks. So we should see whether it is non-response or non-resolution of symptoms. If it is actually a non-response, we should first see whether the child is being given medicines properly, whether the dose is given properly, the duration is proper, the regimen is proper, is the child vomiting most of the doses. So all these are practical issues which we must ask to the parents each and every time they come for follow-up. Non-response could actually be a non-TB. I just said many times we get cases where the diagnosis is actually not TB and wrongly the child is started on anti-tuberculosis therapy. If you don't address a comorbidity, for example, the child is severely anemic, the child is having severe acute malnutrition. If we don't address these issues, the child is not going to fare well to our therapy. That means just giving anti-tuberculosis therapy is not going to cause weight gain in the child. We have to treat the nutrition of the child. We have to take care of anemia, vitamin D deficiency, everything. When we consider all of these things and still the child is not responding, yes, definitely we have to think a possibility of drug-resistant tuberculosis and start investigating likewise. Rarely we may get something like a paradoxical reaction, which actually is a diagnosis of exclusion. What do you mean by paradoxical reaction is sometimes what happens is in any TB, most commonly it happens with a lymph node TB or a pulmonary TB. Once we start the child on treatment, around 6 to 8 weeks after treatment, we may suddenly get fever coming back in the child, pleural effusions coming back in the child, lymph nodes coming up. These are nothing but immunological responses to our anti-tuberculosis therapy. Most of the times they go off on their own. We don't need to treat them. But yes, definitely we have to keep a background of drug-resistant TB in mind. So when do we suspect drug-resistant TB? These are the last 3 slides which I'm going to talk about, 3-4 slides. So what we must understand is drug-resistant TB is usually a primary transmission. That means there is some drug-resistant contact in the family through which the child has acquired a drug-resistant TB. It does not happen de novo into the child, and microbiological confirmation is the most important step for managing a child with drug-resistant TB. There is a very small role for probable DR-TB case where we start the child empirically on treatment of DR-TB. Such decisions cannot be taken at individual level. The child has to be referred to either a nodal or a state center of excellence. A committee decision is taken to start the child on drug-resistant treatment on an empirical basis. When do we suspect, or when we say that the child is a presumed case of drug-resistant TB, there are 4 criteria. First, as we all saw, if there is no response or poor response to the first-line therapy, if the child is taking the therapy adequately as per recommendations for a period of 1 month or 4 weeks, we start suspecting drug-resistant TB. Second, if the child is a lost to follow-up child, that is a defaulter child, the child has taken anti-tuberculosis therapy for more than 1 month, then he was lost to follow-up and is coming back with signs and symptoms of active TB. Third possibility, it is a recurrent or a relapsed TB. Somewhere in the past, the child was treated for tuberculosis and now he's again coming back with symptoms suggestive of TB and is positive for TB. And the fourth, others category. What are the things which we should consider in the others category? If there is a definite contact with the MDR-TB in the household, that is a pulmonary case. Second, if there was a death in the household because of tuberculosis. Third, if the child is a child living with HIV or AIDS. So in these 4 circumstances, we have to start thinking that probably we are dealing with a drug-resistant TB child or drug-resistant TB case. Universal DST, as we all know, it is not only done for drug-resistant TB, but for all TB patients. So it is not restricted to only drug-resistant TB. Definitions, all of us know MDR is considered when the patient is resistant to H and R both. Rifampicin-resistant TB, which we get on Gene Expert, is also treated as MDR TB. This is because 92 to 94% of strains which are resistant to rifampicin are also resistant to isoniazid. The change in the definition has come for pre-XDR TB. So any organism which is fulfilling the definition of MDR TB, in addition, is resistant to any of the fluoroquinolones, either levoflox or moxiflox, is termed as pre-XDR TB. What do we mean by XDR TB? Here, there is a change in the definition. A pre-XDR, that is resistant MDR plus resistance to any fluoroquinolone, and in addition, resistance to any of the group A drugs. In group A of the anti-TB drugs for second-line TB, we have basically 3 categories. We have bedaquiline, we have quinolones, that is levoflox, moxiflox, and we have linezolid. So that is the new definition of XDR TB. Last and the most important section, why I say is most important, because this is the most neglected part. There is a global literature, and the literature from India is also there. Preventive treatment is offered to less than 5% of the eligible candidates, and this has to go up. When we are talking about eliminating TB, if we are only diagnosing and treating the active cases, we are not going to eliminate TB. We have to also pick up the silent cases or the TB infections and treat those. So what are the criteria for giving TB preventive treatment? So any household contacts of pulmonary TB patients, mind you, we are only focusing on pulmonary TB at present. Any household contacts of pulmonary TB patients, irrespective of the age. Today, TPT is offered right from newborns up till old age. So initially it was less than 5 years, more than 18 years, everything is gone. It is offered for all ages from 0 to adulthood. So if we have a household index case of pulmonary TB, in the contacts, we ask for symptoms of TB. If symptoms of TB are present, we investigate the contact for TB. If we get active TB, we treat for TB. If we do not get active TB, then the algorithm goes on the right-hand side. If there is no active TB on investigations, or if the contact does not have symptoms for TB, then we have to start the patient on TPT, that is TB preventive therapy. Now here, arbitrarily, they have made two age groups, less than 5 years and 5 to 18 years. In less than 5-year age group, if the patient is not having symptoms of TB and there is a definite contact, we start the patient on TB preventive therapy. Between 5 to 18 years and even in adults, what the guidelines recommend, ideally, we have to test for TB infection, that is latent TB. And if it is positive, we treat. What are the tests which we use? We can either do a Mantoux test, that is a tuberculin skin test, or if possible, we have to do a interferon assay, that is IGRA. But what disclaimer the programs gives is, if we don't have facilities to test, we have to put all these patients on TB preventive treatment after giving proper counseling and assuring that the patient will complete 6 months of the preventive therapy. Now, preventive therapy initially was only isoniazid for 6 months. We also have an option of 3 months of isoniazid and rifampicin, which has come up this year in 2021, July. The advantage of this therapy over 6 months of isoniazid is this is just a 3 months therapy, and even in 3 months, it is not a daily dose. 6 months of isoniazid we have to take daily, but as far as isoniazid and rifampicin is concerned, it is just a weekly dose. So once a week, we have to take a combination tablet that goes on for 3 months. So you have to give only 12 tablets, that is 1 per week. We must remember that this is recommended only for patients 2 years and above, not less than 2 years. Both these therapies are now available through our NTEP. We have already started putting our children more than 2 years on rifampicin-based therapy. Last but not the least, the addition is initially we didn't have prophylaxis for contacts of drug-resistant TB patients. We now have prophylaxis also for contacts of drug-resistant TB patients. So if we have a pure MDR TB case in the house, that means it does not have any other resistance, that is fluoroquinolones are sensitive, injectables are sensitive. To the contacts of all these patients, after ruling out active TB, there is an option where we can give 6 months of daily levofloxacin. And if the index case is a INH monoresistance case, then to all the contacts of such a case, after ruling out active TB, we can give 4 months of daily rifampicin. So these are certain things which have come up in the past 5 to 6 months and which are very imperative for us to know and to implement. Just by knowing it is not important, we have to start implementing all these diagnostic tests as well as all this therapeutic as well as preventive tests so that we achieve our goal of eliminating tuberculosis. I think that was my last slide. Thank you again. Thank you everyone for a patient listening. Thank you MAIP, Central IIP for giving us an opportunity to share our views. That is our Center of Excellence at JJ. As Madam said, all our staff, all our residents are trained in the recent guidelines. We are managing TB referrals in all the 3 units on a daily basis. In addition to that, for a better follow-up and management of ADRs, that is adverse drug reactions, and if admission required, we have a dedicated pediatric TB OPD which runs every Saturday from 9 to 12:30. Thank you very much.
It was a wonderful presentation on basic of pediatric tuberculosis, how to diagnose them and treat them. Thank you, Shushant sir. Now I would request our second speaker, Dr. Satish Kumar sir. Sir is a public health professional with 17 plus years of work experience in the field of HIV, tuberculosis, maternal and child health, and health system strengthening. He has completed MBBS from Cambridge Medical College and graduation in sexually transmitted disease from Madras Medical College. His core interest is enabling access to quality healthcare in public and private health sector across the country. He currently works as country director at SATHI and oversees the implementation and research activity of selected projects. Sir will be talking on CAP TV learning. Welcome, Satish sir. Kindly unmute and share your presentation. Satish sir.
Pallavi madam, Dr. Satish na co-host केलं का?
Yes, sir. He is co-host.
Then he is not able to unmute himself.
Sir, he is out again. That's why he is not able to unmute. Sir, kindly unmute. You are able to.
Yes. Yes, I'm able to unmute now. Good evening, all of you. Good evening, the Maharashtra team, Dr. Ganguly sir, and the team here. I request Dr. Mayur to share this slide set, please. Dr. Mayur. Yeah. Yeah. So I will rush through, quickly go through this experience of CAP-TB project. CAP-TB project is it's an innovative project where this project is being implemented for increasing the pediatric TB diagnosis in private health sector in India. So you can see the goal of the project is to contribute to reduction in morbidity and mortality due to pediatric TB. And the outcome of this project is to remove critical access barriers to facilitate scale up of pediatric TB in India. This is actually implemented in 10 countries. In India, Sati has implemented this project in collaboration with the TB program. So you can see that the program we have done it in 2 different models. Actually, you can see the entire center circle where we worked in 15 districts of this project, where we worked as district-wide technical support to the NTEP, National TB Elimination Program. We worked in the 15 districts. So the list of districts are shown in the map. Andhra Pradesh, Telangana, Maharashtra, in each state, we have worked 5 districts there. And within that, the bigger circle, we can see a smaller pie of a brown colored one, which is called evidence generation sites, where we work with specific 82 partnership sites, where with the 82 sites, we worked in an implementation research mode to see how the pediatric TB children coming to OPD can be screened and pediatric TB diagnosis can be improved. So that's the overall project outline we worked with. So in this project, we partnered with all the IAP chapters and the pediatricians in these 15 districts. So next slide, please. So we worked for a 3 years project where we covered in the 15 districts, we covered close to 3,048 private healthcare facilities who are treating children, and which included also 1,500 plus pediatricians. Altogether, out of these 3,048 private health facilities, 2,494 facilities got registered in NICSHI, and we supported half of the 1,073, but the government program, the TB program staff have registered rest of them. So altogether in the 3 years, 7,017 presumptive TB cases were identified and reported. 2,000 out of the 7,017 presumptive TB cases, 2,225 TB positive cases are also TB positive cases identified from 7,000 presumptive TB cases. 5,200 plus households were screened, and 115 children were started on IPT, that is primarily the 6 months INH prophylaxis has been started. We have, in partnership with IAP, we have trained close to 1,126 healthcare providers in this project, which involves including 700 pediatricians. In most of the places, we have IAP and Sati worked together and then done these trainings, especially in Maharashtra. It was done in Nanded, Ahmednagar, and Nagpur districts. Next slide, please. So now I will explain our work in specifically, which is of technical medical interest for us from 82 evidence generation sites. So this project, we also worked in doing policy assessment on pediatric TB, and also we worked with the government TB program, the National TB Elimination Program, in integrating the TB services with RBSK School Health Program and RKSK Adolescent Health Program. So that collaborative framework was also released during this project period, so that the guidelines is shown there. So this is just an add-on point. Yeah. So now if we see 82 sites where we work with, what did we do? In 82 sites, every child who is coming to the OPD were screened through a form called ICF form, Intensified Case Finding. This approach is called Intensified Case Finding, where every children who is coming to the OPD were screened for TB. If any child is found to have TB-related symptoms, that is presumptive TB, then the child was evaluated. So in line with guidelines shown by Dr. Shushant Manessa, So the first important thing is chest X-ray support. Chest X-ray was taken, and then if chest X-ray is abnormal, then sample collection was done. So for this project, we have provided financial support to the 82 partnership sites for sample collection support, and for X-ray, if somebody is very poor and wanted support for chest X-ray, we also give that financial support. And we also had an expert radiologist, wherein if the private practitioners want to send an X-ray to the expert radiologist and get their opinion, then that we had a pediatric expert radiologist visit. So we sent the X-rays to them. Then after the sample is collected, the sample transportation was done by the program staff. They carried the sample to CBNAT TrueNAT centers where CBNAT investigation were done. After the results come through, the child is identified as TB positive if the result comes as positive, or if the doctor could diagnose it as clinically TB positive. If TB negative, then the flow ends there. After the child is identified as TB positive, the government FDC drugs, which Dr. Shushant Manessa showed the drugs combination, which is given in the program. So those drugs were given to the patients in the children in the private sector, and every month they were followed up for the drug refill. And also the doctors primarily the pediatricians here. Pediatricians did the facility-based contact tracing and ask for the family history. And then after that, we had a field staff who goes to the home and then did the household contact tracing. And if anybody's child is need to be started on TB preventive therapy, 6 months INH prophylaxis was started. So this is the overall flow of how a child in a private hospital, 82 sites, was screened and identified as TB, and then how the child was managed is shown in this flow diagram. Yeah. Next slide, please. So the first important finding here is that whenever when children are coming and then screened, you can see that average every hospital, you can see average OPD was around somewhere around 1,000 to 1,400 attendees were screened every month per site. So every you can see that among the children are screened. You can see from the beginning, average of 6 presumed to TB case was identified. And when the screening improved, it increased to 11 and 10. But due to COVID, it declined in between. And then again, it further picked up from 2 to 8. And during second COVID, again declined and then further picked up. So what we can see is that when the number of children screening increased, the presumed to TB detection increased. So what we did is to screen, we have given a form, ICF form. So the ICF screening activity led to increase in presumed to TB detection across the program. So, but in between there was a COVID challenge, but otherwise, whenever the screening improved, the presumed to TB detection improved. Next slide, please. Okay, so you can see that number of presumed to TB case identified, out of which how many were evaluated. So you can see in the initial, this is the data of quarter wise. Initially, when 779 children were identified in the first quarter, 304 were actually evaluated. So that means not all the children identified as presumed to TB were evaluated in the first 2-3 quarters. Next, you can press Dr. Mayur. So, but what we can see is that as the period you can see the trend graph, as the period changed from second, third quarters, the proportion of children who are identified as presumed to TB, they were evaluated in a much better manner. So in the starting with 39%, it increased to close to 97 to 89%, 97 or 18. On an average, towards the end of the project last 1 year, almost like 90 to 95% of children identified as presumed TB were evaluated with chest X-rays. So initially, that when pediatricians identified a child with presumed to TB, they treated with a course of antibiotic, but X-ray was not taken immediately. So what we requested is based on the guidelines, we requested them to do an X-ray immediately. And if money is a problem, then they can use the financial support. So when X-ray was taken immediately, over a period of time, the improvement happened there. So to reduce the time delay in diagnosis, every child identified as a presumed to TB shall be investigated with chest X-ray during the same visit is one important learning we found. Next slide, please. So this slide shows the children investigated with X-rays. From 77%, it increased to 89%. And so every presumed to TB case was evaluated with X-ray over a period of time. And the X-rays were also sent to expert radiologists for reading. Yeah, next slide, please. Next slide, please. So after the X-ray is taken, then if abnormal X-ray is found, or still doctors suspect the X-ray may be normal, but doctors suspect is a extrapulmonary or any other TB, then samples were collected and sent for investigation. So we can see that the sample collection increased starting from 32%, it increased to 52%. Again, during COVID, it declined and further it increased. On the whole, 53% of the children with presumptive TB cases samples were collected. So most important thing is that doctors started seeing the X-rays, and with any abnormal X-rays or whenever the doctor I suspect a case as a presumptive TB, then samples were collected. So 53% of the presumptive TB cases were actually taken, samples collected, and immediately it was sent. One of the most important finding is that for extrapulmonary TB also, for especially lymph node or pleural peritoneal fluid also, the samples were sent to CBNAT. So that is one of the most important things. So please collect the sample at the earliest whenever a child is having X-ray abnormality and send it to CBNAT or TrueNAT. Similarly, please send all extrapulmonary TB samples also to CBNAT. That is the next important learning for us. Next slide, please. Yeah. So we can see that the CBNAT positivity yield. We can see that the lymph node aspirate and the lymph node biopsy had the highest yield, was almost like 20%. Whereas when you see the pulmonary samples like expectorated sputum, the gastric lavage aspirate, the gastric aspirate, the positivity rate yield is 4 to 5%. Altogether, in the program, out of 1,753 samples tested with CBNAT, 79 came to be positive. 5% yield positive came. That several studies shows 6 to 8% also, and in our field activities, we found 5%. One of the major challenge we found is that a lot of times the overnight fasting is not done in gastric aspirate. So the child comes in the morning in the OPD, and then after a few hours of fasting, the sample was taken. It is ideally it should be overnight fasting and then do it, but practically this is how it was done. So one of the important issues is the quality of samples that has to be addressed. Next slide, please. So out of the total samples we have tested for, we have out of the total presumptive TB case, 11% of the presumptive TB case were found to be TB positive. So this graph shows that whenever the presumptive TB case increase happened on a quarterly basis, the TB positive diagnosis also improved. So with systematic screening, we can identify more presumptive TB, and if we identify more presumptive TB, we can identify TB positives. So this is a core learning we had. So what does it translate to action is that if any child identifies as presumptive TB, if we investigate and evaluate systematically based on the guidelines Dr. Shushant Manessa clearly explained, we can identify more TB positives is one core learning we have identified. Next slide, please. Majority of the TB cases we identified were children less than 6 years, because the partnering sites, 82 sites are pediatricians. We identified among them majority of the children who are identified 50% 0 to 5 years. So the most important thing here is that the 0 to 5 years and 6 to 10 years, we were able to identify more children, and because of that we were able to bridge the gap of 0 to 5 years. Dr. Shushant Manessa said how the gap in this 0 to 6 years. So because of engaging pediatricians and with sample collection and all the investigations, we were able to identify more younger children with TB. It's a similar proportion of males and females. 1/5 of the cases were microbiologically diagnosed. Among those TB positives, 1/5 were microbiologically diagnosed. That means even though 50% of the samples were taken, but the microbiological diagnosis 20%, still clinical diagnosis holds good in the experience. Next slide, please. And after that, cases were identified. They were started on public sector FDCs, and we can see that initially there were 79% of the children were started on government FDCs, and it increased to 89 or 90%. So still we found 10 to 12% doctors they were prescribing private FDCs, but they themselves recognized that the doses are unstandardized and you have to split the tablets and given. But people who are started prescribing the government drugs, they felt it was very easy to give the drugs from the government program, and they switched to that. So please use government FDCs for the standard dose, and it is available as free of cost, and the program gives monthly drug refills so that good adherence can be ensured. Next, please. So in summary, we can see that out of 11 lakh children attendees, 8 lakh children were screened, and we found symptomatics, generally some symptoms of TB is 5,32,000, but specific symptoms of TB, presumptive TB is 3,499, out of which we found 395 TB positives. So number needed to screen to identify presumptive TB case 240, number needed to screen to identify TB cases 2,129. So every 2,000 children screened, we were able to identify one TB positive is our experience here. So it is that means if a very good 1,000 OPD or 500 to 1,000 OPD sites are there, they would be able to identify 1 to 2 TB cases per site per private hospital in every 1 or 2 months, and they can report the TB cases. Is our learning we found. Next, please. After that, we did the reverse contact tracing for 93% of those TB positives. That means we went to the home and then found that 45 children were eligible, out of which 33 were started on IPT, 73%. The good thing is that pediatricians understood the importance of the contact tracing, and they also did the facility-based contact tracing. And in the community, we were able to talk further on that. If the pediatrician talk about the the IPT, isoniazid prophylaxis, when we go to home and then start them on IPT, they were able to believe it. But if pediatricians don't talk about the importance of IPT, then when we do in the home visit and identify eligible children for IPT, they don't start IPT. So the connection between pediatrician is very, very important. Next slide, please. So the key learnings, this is 1 or 2 last slide. The key learning is that through this project, we were able to demonstrate that integrating systematic screening for child for TB at private health facility is feasible. Pediatricians' engagement is essential to bridge the gap of 0 to 5 years detection. Engaging high load pediatric sites. These 82 sites are high load pediatric sites. So they were able to engage as hubs, so they can provide comprehensive pediatric TB. So the program, the National TB program, is now trying to partner in each district few sites as hubs for like this, so that we can identify more TB cases. Periodic sensitization training helped improve the adherence to diagnostic algorithm. The financial support given for sample collection and also sample transportation support increased the evaluation of CB with CBNAT, TrueNAT, and also linking with the government drugs help to get the drugs easily. Next slide, please. So the take-home points are that identifying presumptive TB and evaluating them with chest X-ray on the same day of visit helps in early detection, and also the chest X-ray evaluation helps to identify early detection of the abnormal X-rays. Any child identified with abnormal X-ray suggestive of TB, then it is very important to do sample collection. So taking a chest X-ray on the same day of a presumptive TB case visit is very important. Support of expert radiologist helps to address any areas of clarifications in diagnosing the TB case. CBNAT testing for all pulmonary and extrapulmonary samples is possible and is important. Clinical diagnosis is important among younger children because the yield of TB positive is very less among younger children due to possibasal in nature. So clinical diagnosis still holds good. Coordination with the TB program staff is very important, and it reduces the cost of the treatment under the free CBNAT. And the last is the delivery of the free government FDC drugs to private if the patient and the private practitioner wants to continue the treatment in the private sector. We don't need to refer all the cases to government. If we want to continue the treatment in the private sector itself, it is possible. So these are the take-home messages from our project experience. Next slide, please. So we gave to all the 3,000 pediatric sites, we gave them this FDC drug chart and also the IEC materials on the TB screening. And it was very, with that support, we were able to identify a good number of cases. However, it was not a magnanimous increase because of COVID. We had a lot of challenges, but however, it was the pediatrician support was very, very helpful to identify and report more cases. So this is our learning. I will stop here. Thank you all.
Thank you, Satish sir. It was a very enlightening presentation on catalyzing pediatric tuberculosis. Now I invite our third speaker, Dr. Ramji Adkekar sir. He is Joint Director, TB Leprosy, Maharashtra. He has 26 years of experience in health system strengthening under Public Health Department, Maharashtra. Sir will be talking on NTEP IAP engagement roadmap. Welcome, Dr. Adkekar sir. Kindly unmute and share your presentation.
Yes, thank you, madam. Am I audible?
Yes, sir.
Yes, sir.
Is my screen visible?
Yes, sir.
Thank you. So first of all, I would like to thank MAHA-IAP and Dr. Hemant Gangulia ji for organizing this meeting and Sati for coordinating this meeting. I really appreciate the efforts of IAP for organizing this meeting in January month, because we have sufficient period in our hand to improve the performance of pediatric TB and to coordinate with all the pediatrician in the Maharashtra. So without wasting much time, I will show that if we look at the trend of TB notification in Maharashtra from 27 to 2021, in the year 2019, Maharashtra detected more than 2 lakh, that is 2.26 lakh TB cases. But in the month in 2020, due to pandemic impact, there is reduction in the TB detection, and we could detect only 1.60 lakh cases. And that pandemic had impacted in case detection as compared to 2019. Maharashtra detected around 70,000 cases less as compared to 2019. But in 2021, in spite of the second wave of COVID pandemic, we could detect around 2 lakh TB cases. And because of our efforts and the support from private sector, especially after June, we could detect more than 1.99 lakh cases. That is a better improvement if we look at the case detection in 2020. So what is the contribution of TB cases in total TB notification? So in 2017, it was 5.6%, and in 2021, it is 6.3%, but still it is less than 7%. Actually, we expect around 10% of pediatric cases out of total TB cases, but because of the many reasons, we could not detect expected number of pediatric cases. And definitely, as Dr. Shushant Manessa explained, that there is a gap in the diagnosis, and definitely this can be improved with the help of IAP. The contribution of TB cases among total TB cases, the trend in public and private sector. If we look at the notification in public sector, it is in the range of 5%, but in private, it is more than 7%, and in 2018, it was more than 8.4%. So in public sector, there are many challenges in pediatric TB case notification, but as compared to public sector, in private sector, pediatric TB case notification is better, even though it is also less than 10%, but definitely with the help of private sector, we can improve pediatric TB case notification in public and private sector also. So what is the number of microbiological cases in Maharashtra? Around 59% cases are clinically diagnosed, and around 41% cases are microbiologically confirmed cases. So here, the microbiologically confirmed cases percentage is less as compared to the clinical diagnosed cases. And Dr. Shushant Manessa had very well explained the role of clinical diagnosis. So upfront use of NAT for TB diagnosis as per NTP diagnostic algorithm, it is very important. It was very well covered by both the speakers, and collection of appropriate biological specimen. In Maharashtra, there are more than 141 CBNAT machines and 79 TruNAT machines for the molecular testing, and this number is going to be increased in 2022. We will be procuring additional 150 TruNAT machines and around 25 to 30 CBNAT machines, so that we can increase our NAT testing, and we can definitely supply these machines at TU level also. That is our plan, to expand our NAT testing at the TU level also. So upfront use of rapid molecular test for TB. In public sector, it is 34%, and in private sector, it is 23%, and total, it is only 28%. We know there are problem with the NAT testing, but now we are increasing the number of CBNAT machines and TruNAT machines also. There is no problem of CBNAT cartridges and TruNAT chips henceforth, because Government of India and Government of Maharashtra has ensured regular supply of TruNAT chips and CBNAT cartridges, and we hope that in 2022 our upfront molecular testing, it will be improved, which is right now it is 28%. So again, upfront use of NAT is very important, and definitely we will ensure to all the pediatricians that whatever samples being sent from the private sector, we ensure that all will be tested through NAT, and definitely in 2022 we will have sufficient number of NAT machine, that is CBNAT and TrueNAT. Proportion of DRTB cases in 0 to 14 years. If we look at the data, 7% of the cases are DRTB cases. In public sector, the percentage is 8, and in private, it is 6%. Proportion of extrapulmonary cases, if we look, lymph node cases are 2088, and after that, abdominal cases. And we know that what are the challenges in diagnosis of extrapulmonary cases in 0 to 14 years age group. And definitely with the help of IAP and pediatricians, we will definitely improve upon the performance of 2021. So 50% of extrapulmonary cases need to establish system for extrapulmonary sample collection and establish hub and spoke models. I will discuss it in detail in further slides. Now, TB preventive treatment, Dr. Shushant Manessa explained the importance of TB preventive therapy in under 5 years age group. In Maharashtra, from 2021, we have started to implement latent TB infection in 30 districts through union and 21 districts through NHM. Again, this year we are going to increase the number of districts for the TPT. Of course, there is no issue for the children below 5 years age, but for the children above 5 years, we go for the testing. And as Dr. Manessa explained, in case there is any problem in the testing, we can start the TPT also. But definitely, if you look at the performance, TPT provided to only 30% of the children and TPT not provided to 63%. So this number is very high, and we need to focus on TPT if we really want to prevent tuberculosis, or if we really want to achieve our goals of end TB by 2025. This is going to be one of the most important activity. Of course, with the help of IAP and pediatrician, we will improve our performance in 2022. So diagnosis and treatment of LTBI is very essential for rapid decline in TB incidence. TPT uptake in private sector is low. Definitely it is low, but with such meetings and such type of coordination with the IAP and pediatrician, we can improve our performance in private sector also. Right now we have 11 patient provider support agencies, but in 2022 we are going to engage PPSA in all the districts. Definitely with the help of PPSA, we can increase the performance of TPT, and counseling of family members is a key. In private cases, if pediatrician or any private doctor, if he convince the patient regarding the importance of TPT, then a patient definitely agree, or he definitely support for the TPT, and that's why it is very important to counsel the family members. So what are the challenges? These challenges are already mentioned by Dr. Shushant Manessa and Dr. Satish Kumar. Difficulty in obtaining samples, especially from younger children, involvement of private sector in addressing pediatric TB burden. But as I said, with the help of PPSA and with the support of IAP, we will definitely get the support of all the private sector and pediatrician. Long chemoprophylaxis, significant undernutrition among children, unavailability of child-friendly formulation for DRTB patient. So what are the efforts made by NTP Maharashtra? As we have seen, Dr. Shushant Manessa explained that JJ Hospital Mumbai is a center of excellence for pediatric TB, and BJMC is another center which is working as a pediatric center of excellence. Private sector pediatric DRTB model, Wadia Hospital, it was first in the country, and state has recognized it as a district pediatric TB center of excellence. So definitely there is very good example of Wadia Hospital. Access to pulverization of DRTB drugs for the children, strengthening of private sector engagement for pediatric TB control activities through JIT PPSA. Most of you are aware that JIT was working in 13 corporations, but that project has come to end on 31st December 2021. But with the help of PPSA, we will definitely work in the private sector, and luckily almost all the districts of Maharashtra will be engaging PPSA in 2022. Collaboration with RBSK and RKSK for identification of presumptive pediatric TB cases, as mentioned by Dr. Satish Kumar. Regular screening of children admitted in nutrition rehabilitation center. In Maharashtra, we have NRC in all the districts. At least one NRC is there in every district. So what are the expectations from IAP? Notify each and every pediatric TB case to all district TB officer under NTP. And as Dr. Shushant Manessa explained, that it is mandatory on the part of all the private practitioners to notify each TB case to use upfront molecular diagnostics. As I mentioned, we will be having sufficient number of CBNet and TruNet machines this year, and we can definitely increase the number of districts going for the upfront molecular diagnostic. In Mumbai, there were 12 districts which were using upfront molecular diagnostics, but in 2024, almost all the 24 districts of Mumbai will be going for the upfront molecular testing. Offering TB preventive therapy to the identified at-risk and eligible child population. Here we definitely request IAP for their support. If IAP and every pediatrician support, then only we can improve TPT. Participation in NTP training programs organized for public and private sector pediatric TB practitioners to conduct regional CME as per the MOU of Central TB Division with the Central IAP. I really appreciate the efforts of Maha IAP for organizing this meeting, and I know that you regularly organize CME, and I really appreciate your efforts for organizing these such CMEs to support NTP in sample collection, diagnostic, hub and spoke model. So this is going to be a very important support which we will be expecting from the IAP. Conduct pediatric TB awareness and promotion activities for enhancing TB notification. So how we can engage? What are the strategies for the engagement of pediatric TB? I will take only few minutes to explain this. National TB Elimination Program has state and district unit. So each district implementation is managed by a district tuberculosis officer, and for corporation, we have a city tuberculosis officer. So for the effective management of tuberculosis program, we have 80 districts as far as NTP program is concerned. In Mumbai, we have 24 districts. For each corporation is considered as a NTP district, and all 34 rural districts are also considered as NTP district. So under the DTO and CTO, we have PPM coordinator. He is public-private mix. He is a person who is identified for the coordination with the private sector, maybe private practitioners and pediatricians also. So he is going to be a key person who will be coordinating with the private sector. And also we have ground level staff called Senior Treatment Supervisor, STS and TBHVs at our TU level. PPM coordinator will build rapport with the district IAP president and IAP secretary of each district. So with such frequent meetings, we will definitely ensure that our PPM coordinator will be in touch with all the private practitioners, especially all the pediatricians. And we request IAP to share contact details of all the office bearers. Then the PPM coordinator will collect a list of pediatricians in the district from IIP president and secretary, along with a letter from IIP requesting the pediatricians to get themselves enrolled in Nikshay and notify all the pediatric TB cases, including presumptive TB cases in Nikshay. So we all know that detection of presumptive TB cases is very important. As Dr. Satish Kumar mentioned that when presumptive TB cases increase, and then TB cases get increased. So that's why it is very important to detect all the presumptive TB cases and to enroll all the pediatrician in Nikshay. Most of you must be aware that we have one portal, that is Nikshay portal, where all the details of TB cases and every detail of services provided to the TB patient is entered in Nikshay portal, and there is definitely access to the pediatricians also. They can enroll themselves in the Nikshay so that they can notify all the pediatric TB cases. PPS and NTP field staff, that is patient provider support agency, which we will be engaging in all the districts, and NTP staff, field staff will visit all the pediatricians in the district and ensure their enrollment. As I mentioned that PPSA, they will contact all the pediatrician, our NTP staff, especially our PPM coordinator, STS, and TBHV, they will come to you, they will contact you, and they will definitely the work on your suggestions, and which will definitely improve our performance. So there is a request, IAP shall identify pediatric sample collection center. This is very important in pediatric TB diagnosis. Collection of pediatric sample is a major challenge. In such cases, if we could identify collection centers, then definitely that will help us in diagnosing the pediatric TB cases. Then which will definitely enable referrals by all pediatrician and GPs, local practitioners, to refer children in need to this sample collection site. If it is possible, IAP can identify 3 to 4 active members from each district. I mean, active members mean pediatricians. IAP state Maharashtra, if they could compile such 3 to 4 pediatricians from each district, and if it is shared with the STO office, then we, from our level, we will coordinate with our district tuberculosis officer, city tuberculosis officer for the effective management of NTP program, and we request one member as IAP TB champion from each sub-district geography. The role of IAP TB champion is to inspire their members, and definitely such kind of meetings are definitely to inspire all the members to notify all the TB cases, and such kind of talks and presentation from the experts from the different medical colleges and our senior pediatricians, experienced pediatricians, which will definitely help us. NTP and IAP shall meet once in every quarter to review progress in all the district as far as pediatric TB notification is concerned. NTP with Pediatric Center of Excellence support will establish technical support unit to help pediatric across Maharashtra and address their queries with respect to pediatric TB. NTP will take support of the district IAP chapter to sensitize other private practitioners. NTP along with IAP will organize periodic children screening camps, and we definitely seek support from the IAP. Of course, we have RBSK and RKSK, which through with the help of which we are able to diagnose some of the pediatric TB cases. The NTP will invite representatives of IAP along with other stakeholders in all the respective forum meetings at district. Your support will help in improving prevention, early detection, and treatment of pediatric TB in Maharashtra. I really thank Maha IAP and all the dignitaries who have participated in this meeting and made their presentation and given their inputs for the improving the performance of NTP in 2022. We have started well in advance, and definitely this will help us to have better coordination with IAP and all the pediatricians working in different districts of the Maharashtra, and we will frequently meet so that we work for the end pediatric TB by 2025. I once again thank you everyone for the patient hearing.
Thank you, Dr. Hadkekar, sir. It was a really fantastic session. All the speakers and their presentations were excellent. Now I request our Maha-IAP State Convener, Dr. Jay Bhandarkar, sir, to discuss few questions from the chat box with our guest experts and speakers. Over to you, sir.
Thank you, Neha. And this first question from our infection specialist, I must say all three of our speakers so excellently presented that within a very short period, right? I think they
can you stop sharing, please, sir?
Just a minute.
Yes, sir. Yes.
Thank you. Yes, sir. Thank you.
Thank you.
There are a few questions in the. I can say that thank for a very excellent presentation, and that in a very speculated time, and very well covered. The topic of TB is so vast. There are a few questions, and first question is from our Dr. Pramod Kulkarni. He himself is an infection specialist from Pune, and is a EB member also. So he has asked. Sorry. Is the detection gap of 50 to 60%, 70% an estimate by mathematical model or in real? Dr. Shushant, we have mentioned that detection gap of these TB patients.
So it is done by the epidemiologist using the mathematical model of logistic regression. But the data which is collected from the different districts, it is extrapolated to these softwares which are there, and then they calculate. Okay. So it is almost accurate.
Thank you. And another question is, what is CB0 Ultra? Dr. Jitendra Grawner from Mumbai.
Yeah, so that is Gene Expert Ultra, which is a little more advanced technology as far as Gene Expert is concerned. The sensitivity is much more. The machines are already there in India. We are hoping that in Maharashtra also we start soon. I think Hadkekar sir would be able to tell us better, because in national centers they have started using Ultra, and we are hoping that we also get, because it is especially useful for pediatric TB and for extrapulmonary samples like pleural fluid or abdominal nodes or CSF, where the normal CBNAT would come negative, but Ultra would come positive, because the detection limit which is there with Ultra is much lower as compared to the normal CBNAT. So the sensitivity is much higher.
Much higher, yes. Okay. So it's one question. Any role of TS test, a tuberculin test and IGRA in diagnosis of pediatric TB? Specific.
No, so no role in diagnosis of active TB. It is for diagnosis of TB infection, as we said in the preventive therapy section. One exception I would say is in case of pleural TB. So because in pleural TB, what happens most of the time is when we take aspirate the effusion, we get the effusion which is characteristic of TB. That is, the proteins are high, it is lymphocytic, and most of the times the CBNAT comes negative. So in that case, if a TST comes positive, it just adds on to a diagnosis that the patient is having clinical features of TB. A pleural fluid is exudative, supporting TB, and his Mantoux test is also positive. Apart from that, for active TB, IGRA and a TST should not be used. It has no role. It is only for diagnosing TB infection.
There's a question, were there any changes in the screening of household contacts?
So changes is, there are no changes. The thing is, initially it was restricted to certain age groups. Now it is done for all ages, right? From children up till adults. So what the recent guidelines which were released in July 2021 says, the preventive therapy has to be offered to all the household contacts. So as we said, the screening is first is a symptom-based screening. If anybody has symptoms suggestive of TB, we directly go ahead with an X-ray test, and then if required, the molecular test. If the patients don't have symptoms of TB, then we offer them preventive therapy. If they are adult, in the adult age band, we try to get an IGRA done and then offer. What happens is, it is okay if we don't test and give therapy. But then sometimes what happens is, especially in the educated section of the community and the upper strata of the community, it is very difficult for us to counsel the parents to take preventive therapy for 6 months. What happens? First of all, there is a resistance that we don't want to take. We don't have active TB. Why should we take? Latent TB जब active होगा तब देखा जाएगा. That is one thinking. Another danger is sometimes they may start, and if they are not convinced or we have not made sure that they are convinced to take treatment, they may take for 2-3 months and then stop. So that is why it is the program says or the guidelines say, if we have a possibility of doing an IGRA and show a positive report, you have a significant infection, it is better you take it. Then it improves the acceptance and it improves the compliance to therapy. But then if it is not available, we should not withhold preventive therapy. We should still counsel and give.
Dr. Shushant, I have one question. When you talk about the TB, we are more worried of a MDR or the XDR, right? And we say when it is in pediatric patient, when you suspect XDR or MDR, basically they get the infection from the adult, right?
Yes.
I don't know that the preventive treatment previously very stricted to the INH once a day dose for 6 months. What are the specifically give together post measles infection? So commonly only the all pediatrician use. Now, whether we can give this in MDR patient, already you mentioned about the levofloxacin, later the rifampicin also in the preventive therapy.
Yeah.
Suppose in we know there is a difficulty in diagnosing pediatric patient. We go for a bacterial diagnosis, which is not sometimes not possible. Suppose I have a primary patient of MDR TB in our home. Whether I can start the suppose the child get some infection of tuberculosis, whether I can take it as an MDR tuberculosis directly. So it doesn't able to prove whether it is MDR TB then.
So that is what I said. There is a provision for that, but it should not be the first step. First, we should attempt to get a sample. If we don't get a sample, or if we get a sample and it comes negative, then definitely if there is a household case, there are cases where we also start the child directly on MDR treatment because it is a close contact. But then what happens is we should not bypass that sample collection step, which is most commonly happens as a reflex response. घर में MDR है तो इसको भी चालू कर देते. Not like that. So we have to do a gastric aspirate maybe once or twice if the child is having features of active TB or maybe a cervical lymph node. If we don't get it, then yes, we are definitely justified in starting the child on MDR treatment. Because if we remember the chart of presumptive TB, one of the important risk factors for a presumptive TB is an active case in the household. So that becomes a criteria that we consider DRTB very strongly in the child.
So means the perfect take-home message is we have to go for a microbiological or bacteriological diagnosis in each and every case.
Each and every case.
And to attempt all this gastric aspirate, BAL and other things. Suppose you're not able to do in your hospital, you have to refer, and then you can go for the preventive therapy. Right?
Yes, absolutely.
There are two questions. Won't take that also. Why to keep that?
This is the questions.
MGIT liquid culture is one of the question asked.
So what is the question about the culture?
Yeah.
MGIT. What is MGIT? There is a liquid culture.
So liquid, the method which is used for liquid culture is known as MGIT. So it is one and the same thing. Mycobacterial growth indicator tube. That is the method which is used by the microbiology labs to do a liquid culture.
And one more question is, yes.
All the cultures used are only liquid now. Nobody is using solid culture. Solid is done by the referral laboratories, national and intermediate referral laboratories as a backup. But most of the cultures are solid, liquid now.
And one more question is from Dr. Sanjay Deshmukh. Clinical diagnosis who start AKT in suspected child is more prone to have wrong. Most have seen to started only on basic of enlarged lymph node without further investigation. So
that is what we said.
Yes.
That is what we said. If you have enlarged lymph nodes, so if we have a cervical lymph node, first we take a history whether it is fitting into the symptom of TB. If it is more than 2 weeks, we palpate the nodes. If they are having, matting, if the nodes are matted, or if we find pus or something like that, then we try to sample it first, do a guided aspiration, send it for gene expert, and then we progress. If most of the times what happens is, this is a common question which is asked to us, is FNAC better or excision biopsy better?
Yeah.
So if what the single answer would be, if we have a significant amount of pus in the lymph node. Now pus is a very good sample for a gene expert or a culture to come positive as compared to a tissue, lymph node tissue I'm talking about. So if we have pus, we should always do a guided aspiration, take at least 1 to 2 ml of pus and send for investigation. If we don't have pus, if there are just matted lymph nodes, that is only tissue is available, it is always better to do an excision biopsy first hand. I'll give you the reason. What happens is FNAC is a very blind procedure. We just go inside the lymph node. Now, inside a lymph node, we can imagine TB is not there everywhere. There are certain areas where we get those Langerhans giant cells and granulomas. So if the needle does not hit the right area, okay, we are not going to get those cells in our FNAC smear. We are not going to get AFB. And that is why if we just have lymph node without pus, upfront excision biopsy would be a better specimen, because what happens most of the times is FNAC is done, it comes negative, child is still suspected to have TB, and then we have to again convince the parents to go ahead and do an excision biopsy. So sometimes the parents are a little, anxious to get procedures done.
I have a question.
There were a few questions which have been answered by the respected Dr. Satish and Dr. Mayur also. So that questions are answered. Now no more questions are seen. Yes,
Question from my side.
Last 5 minutes.
Okay.
There is one question from Ramakant Patil, sir.
Yes. Boliye na Mayur. Mayur, please tell.
Yeah. So that is for Dr. Shushant, sir. Is it necessary to have 2 negative gene expert with positive symptoms and X-ray, or only 1 negative gene expert is enough?
Is it necessary to have two negative gene expert with the positive symptoms? Yeah.
Yeah,
so
like to diagnose.
Yeah. So if the X-ray is very characteristic and the symptoms are characteristic, it is always better to take 2 samples. Again, the reason being, in our country, the background drug resistance is quite high. So we should not miss a drug resistant TB. That is the scenario. So if we see what happens, I'll tell you, most of the times if the X-ray is characteristic and the gene expert is coming negative, then most of the times it is a sampling error, what we have seen. So there are so many referrals which come to us. There is a cavity sitting in the X-ray, or there is a huge consolidation. CT scan is done. CT scan shows tuberculosis, nodes, everything, caseation. The patient is referred to us for starting treatment, or maybe started. And gene expert is done, but it has come negative. And when we do, it comes positive. So basically, what I said, every one of us must go through the CTD website and see those videos. Those videos are very beautiful. What we do in JJ is, whenever we get time, every 3 to 6 months, we train our new residents batch. We just show them these 10-minute videos, because it creates a lot of difference. How do we collect the sample? How do we do chest physiotherapy to take out induced sputum? And then once you collect it, in how much time it should go to the lab? That is also very important. Collecting a sample at 9 o'clock in the morning and sending to the lab at 6 o'clock in the evening again is not wise. It has to reach the lab in a particular time frame. So that is why it is said, if you have a characteristic X-ray, make it a point to get the sample twice at least.
Okay. What is take on this stool gene expert test? Because induced sputum and gastroscopy is an invasive procedure, and stool is very easy to collect. We mentioned it's gene expert stool examination also can be done.
Stool gene expert, the test which is approved is the gene expert ultra by WHO. Okay. Not the normal gene expert, and the sensitivity which has been found in studies is quite good, around 62 to 64%. So this has just come up in the 2021 guidelines. That what I can say, the position paper has been released. The detailed guidelines will be released by WHO in March 2022. So I hope NTEP will incorporate it. Right. Because stool is easier to collect, but then we should have an ultra machine for that. We cannot run stool on a normal gene expert machine.
No specific questions. If any. Dr. Amol Pawar, welcome.
Dr. Neha, please. Dr. Neha, please.
Thank you, Jay sir, for handling the question answer session. Now I acknowledge the presence of Dr. Kinikar ma'am from BJ Medical College. She is the regional head of Center of Excellence of Pediatric Tuberculosis in 4 states. Ma'am, kindly unmute. We want few words from you.
She's there.
Yeah, she was.
I think ma'am dropped from the call.
Okay. She was there.
Okay.
Huh? Okay.
Dr. Mayur Manessa, sir, please few lines from you. Dr. Mayur Manessa is Sathi coordinator. Yes, sir.
In the backbone.
Yeah, so I would like to thank IAP for organizing this meeting. This is a follow-up meeting after the CAP-TB dissemination, and as rightly said by Adkikar sir, that as we are just starting the year, so this meeting will help us to move ahead and to identify more the pediatric TB case and to reach the target of 10% and even more than the 10%. And I also like to thank the NTP department, Dr. Arkikar sir, and also Dr. Kadu, state WHO consultant, has joined the call. State PPM coordinator also joined the call. So I thanks them for attending the call. Even PPSA partners, HLPPT, Alert India, Disha, they have joined the call. So they will be there in the field to support all the pediatricians to address their queries. And all the IIP members, thanks for joining the call. And this coordination will definitely will support to address the pediatric TB issue. Thank you.
Dr. Mahir, do you want to invite somebody to speak something? WHO consultant and anyone you want to ask anyone?
Dr. Kadu sir.
Unmute kara sir.
Dr. Kadu sir, you want to say something?
Pallavi madam, Dr. Kaduna. Yes.
Thank you, sir. So it was excellent presentation and excellent coordination by Sathi, and we will definitely build on this Sathi's experience for betterment of pediatric TB diagnosis in NTP. Thank you very much.
Sir, thank you. Just want to add, this is Dr. Satish from Sathi. I request the IAP leadership who has kindly made this arrangement to find out to nominate 1 or 2 representatives from each district and share the list of IAP champions, TB champions to the state TB office. And like Dr. Mayur explained, we have the partners who are working in the TB program. They are also have attended here in this call. So those partners can contact the IAP champions in each district. In each district, if one champion, we can go and meet them. So if we can launch a campaign more to March 24th with the World TB Day, we can ensure that all pediatricians and their hospitals can be registered as a campaign. We can do that, number 1. Number 2, 24th TB Day, so that throughout the state of Maharashtra, 4,000 plus pediatricians in the state can be paired with 1 or 2 IEC materials on the guidelines, on the IAP, the TB treatment chart, everything, and make everyone register and report in Nikshay. So I would request us to keep up to continue this momentum here and track it on a close basis, on a monthly basis till the World TB Day, and from there the momentum can take it forward further, sir. So I would request for this to be continued in a mission mode.
Dr. Satish sir, we have taken the cognizance of that, and we have 42 IIP branches all over the Maharashtra, and we are already in the process of sending the mail asking for at least 2 nodal coordinators from each of the IIP district branch. There are 42 in our Maharashtra state. So we'll get back to you with the list.
Okay. Oh, thank you, sir. Thank you so much for all this great work. Thank you, sir.
Thank you, sir. Now I request our IIP Secretary General, Dr. Amol Pawar, sir, for vote of thanks. Over to you, sir.
Thank you, ma'am. Before that Amol speaks, anyone who is present over the Zoom, anyone want to give 1 or 2 comments? Then we will go to Amol Pawar. Anyone?
RD sir, Ramakant Patil sir.
Yes, because the EB members RD, I am seeing RD. Nanudekar sir was there. I don't know whether he's there. And Jitendra Kavani.
I am very much there.
Yes.
Excellent presentation. Shushant and all the speakers, 3 kudos for all the 3 speakers. I think are there any whatever newer body or guidelines or some modification which were told by Varinder sir? Have they been incorporated in this CAP TB?
Somebody should mute. जय सर.
हेलो. हाँ ठीक है.
नानी सर बोला.
अमोल. हाँ नाही, सेशन छान झाला. It was very much needed आणि सगळ्यांच्या कोऑर्डिनेशननी we will see to it that all the cases are detected properly and are so there is no overdiagnosis. Both under and overdiagnosis is bad. Okay. Thank you for the nice session.
So Dr. Nanivedekar, once we prepare the list of the nodal coordinators all over the district Maharashtra, probably we will make you the in charge of that, and you have to look out at that. Okay.
Yes, no problem.
Yes.
Okay, chalega. Yeah.
Okay, it was a very much informative session on about pediatric TB, and there is a lot to learn from these stalwart speakers about pediatric TB, which will help our general pediatricians of MAHA-AP in day-to-day practice. I thank all the speakers, all the stalwart speakers, Dr. Ramji Adkikar, Dr. Shushant Manessa, who is a smart, young, dynamic IAPN from JJ Hospital, Mumbai. Dr. Satish Kumar, we met at Pune meeting. MAHA-AP plans to arrange many more such sessions in this year, 2022. And I thank all the attendees for their patient hearing. And I thank all the dignitaries, Dr. Bela Verma ma'am, Dr. Nani Odekar sir, Ramakant Patil sir, and all the office bearers of Maharashtra IAP branches. I thank one and all. And over to you, Neha ma'am.
Thank you, Amol sir. Friends, mortality due to tuberculosis is the highest among children. Many organizations are working on an initiative to ensure that children, especially the drug-resistant ones, have access to child-friendly medicines, which dissolve in water and tastes better and are easier to swallow. And for this, we need to move forward and need strong commitments and energy to save our future generation from the second biggest infectious killer disease. By this note, I end the session. Thank you so much, all of you, for attending today's session. Thank you.